Hello, this is Cheryl Sadowski. Welcome to the lecture on lower urinary tract symptoms in Pharmacy 397. You have a number of resources that you can use to supplement your learning in this area. You have a textbook available through the University of Alberta Library, and there's 2 chapters that you can read. This is not required reading, but again may help you in understanding some of these concepts taught by myself or by the nurse educator on urinary incontinence. RX Files also has some helpful tables. There's many different drugs and drug classes used in treating lower urinary tract symptoms, and this might be a helpful resource, especially when we're going through the cases in the seminar. RxTX also has multiple short chapters with references for Canadian content on medications and non-pharmacologic treatments for lower urinary tract symptoms. You may find all of these helpful in your study, but again, they're not required. What will be examined will be material that I cover in this slide presentation. You will also have additional study notes that I'll provide. These are meant to be additional notes that might help you in the case studies or in your preparation for future exams such as PEBCs. You may be a bit intimidated by the length of the notes and all of the resources available, but I want to give you an example that will help you understand lower urinary tract symptoms. I want to picture that at the end of term, you're studying and you've stayed late at the university, you've met with a group of friends, you're reviewing so many notes and it's overwhelming. So as you're heading home on the LRT, you get to the end of the line. Maybe you get off at Clairview or Century Park. You're really tired, it's been a long day, and now it's getting close to midnight. It's pretty dark. There's not a lot of people on the train. As you get off, you notice that someone is following you. They start walking, following your path. They have a hoodie on, so their hood is up, and you can't see their face. So you start walking a bit faster. You make a couple of turns, you realize a few blocks away, they're still following you. This person is tracking you. You start walking faster, and so does that person. In fact, you start running. You're getting a little bit nervous. You're a little bit stressed out. Maybe you're thinking this isn't real. You're just so tired and overwhelmed. But this person starts running after you as well. In fact, you start running full speed. You drop off your backpack. You're ready to jump over a fence. But then you stop because you have to pee. Of course, that's a ridiculous story. In that situation, you wouldn't stop. You would jump over the fence. You would do everything you could to save your life. In a fight or flight situation, your body does not allow yourself to urinate. In a fight or flight situation where the sympathetic system is in control, your body will clamp down on those sphincters and relax the detrusor muscle, so your body will retain urine. Urination interferes with survival, and it's in a situation that we could contrast. Say at the end of term, after all your exams are done, all the assignments are in, you're at home watching TV, something that's really quite trivial, just filling in time, relaxing, and a commercial comes on, and you decide you're going to go urinate. So you go to the bathroom, and there's no problem urinating because the parasympathetic system is in control at that time. So when the parasympathetic system is in control, your body will loosen the sphincters, relax the sphincters, and contract the detrusor muscle, which makes you urinate. So this summarizes how we understand lower urinary tract symptoms and how we treat them. Any medication that mimics the sympathetic system is going to make you urinate. Any medication that mimics the sympathetic system is not going to make you urinate, but any medication that mimics the parasympathetic system is going to make you urinate. Any medication that blocks the sympathetic system is going to allow the parasympathetic system to take control and make you urinate. So if I asked you about medications that you're familiar with, such as an anticholinergic medication, you could now predict what's going to happen. An anticholinergic medication blocks the parasympathetic system and allows the sympathetic system to take control, which means with an anticholinergic medication, you do not urinate. So now you can predict, based on the pharmacology of any medication class, what is going to happen to an individual's bladder and if they are going to be continent or incontinent of urine. So that's a very quick summary, but it highlights that you actually understand most of the dynamics for your lower urinary tract symptoms, and there's very little memorization that you will have to do as we go through these different drug classes. There's some important definitions that you should be aware of. Incontinence can also be described as fecal incontinence, or FI. We're not going to discuss that in this particular course. That's covered in gastroenterology. So be careful you don't just say incontinence. You have to say urinary incontinence. We are also dealing with lower urinary tract symptoms, which can lead to urinary incontinence, but not necessarily. Urinary incontinence is the extreme end of lower urinary tract symptoms. So for instance, as we talk about overactive bladder, someone can have those symptoms without actually losing control of their bladder. These are official definitions that are approved by the ICS, International Continence Society, and you'll find in the references provided, both myself and the nurse educator will refer to these as official internationally accepted standards. You might be wondering how common lower urinary tract symptoms are. We hear a lot about it on TV. There's a lot of commercials for the medications. There's lots of ads at primary care networks and doctors' offices. So how common is it? Well, it's an enormous range. We have information from Canada and other countries that range from 3 to 5%. There's quite a range because some studies have found only 3%, but many individuals find it very embarrassing to report that they have lower urinary tract symptoms. They're ashamed to say they wear adult absorbable products, which also might be known as diapers, and they're embarrassed because it makes them feel old, and they're worried if they really cannot manage their lower urinary tract symptoms and they're quite frail, they might be admitted to a nursing home. So many people do not admit they have a problem. They also believe that it's just a part of normal aging. That's untrue. It's abnormal to lose control of your bladder after about the age of 3 or 4. So even much older adults that we would call elderly have lower urinary tract symptoms. That's not considered just a normal part of aging. It's more common with age, but it's not normal. Our best estimates, if we look at a little bit more precise measures from the Canadian Urinary Bladder Study, are that females have closer to 40% prevalence of lower urinary tract symptoms, and men, it's a little bit lower at about 15%. We still believe this is probably underestimated, but this is the best guess in Canada, so you can see it's incredibly common. We also know that it's very high in a variety of settings. In community, so we estimate it's maybe about 25-26%. In acute care, where we give patients quite a bit of diuretic, we restrain them, we put them in a new environment where they maybe can't easily get to the bathroom, they have to call for a nurse. There's more cases of urinary incontinence. And then in long-term care facilities, where we primarily have frail older adults with many comorbidities, we see very high rates of urinary incontinence in that setting. There's a few different types of incontinence we're going to talk about today. Each type we'll go through in detail as to how we define that and then how we treat that. You'll notice the light blue part of these pie diagrams would be stress incontinence, and so for women that's the most common. The orange color is urge incontinence, and you probably hear more about that simply because there's far more medications, quite a bit of competition in the pharmaceutical market for urge incontinence, and so some people perceive that that is the most common, but that's not the case. So the bottom line for epidemiology is that lower urinary tract symptoms are very common. It's more common in women, and you will see it in every practice setting. So it's not just in nursing homes, it's also in the community and acute care. So no matter where pharmacists work, they need to be familiar with this condition. We are also going to talk about BPH. So this is growth of the prostate. What is reassuring is that it's not considered cancer, so it's benign. However, when you have any organ growing inside the pelvis, there's not a lot of space for that, and so other tissues become compressed. So in BPH, it's not cancerous growth, but it is growth of the prostate, and that often compresses or closes off the bladder neck. And so that causes urinary symptoms where there's retention, because when the bladder neck is closed off, men cannot force the urine past that closure. You'll see as men get older, they have quite a few symptoms. So over the age of 85, almost all men have this change. If they don't have urinary incontinence symptoms or retention, then we're not too concerned. But once they start having symptoms, we do have to intervene. The burden of incontinence is quite significant. Some of these images show a few examples. People become less social. They're quite embarrassed by being out with friends if they smell of urine or if they have leakage. So we have fewer people doing activities such as bike riding or going to the gym. They're embarrassed even to socialize going to a restaurant. They're afraid to drink anything. And so people often isolate themselves if their lower urinary tract symptoms cannot be managed. We also know people with lower urinary tract symptoms have much higher rates of depression and will actually seek out treatment with an antidepressant. So those two conditions commonly occur. If we can better manage the lower urinary tract symptoms, often individuals do have improved mood. The image on the left is repair of a hip fracture. When individuals are quickly trying to run to the bathroom, they are more likely to fall, not just because they're moving quickly, but when you really have to urinate, such as an overactive bladder, suddenly your detrusor is contracting and you're not running with a normal gait. There's an abnormal gait pattern that occurs. And so people are at risk for falling and injuring themselves. They don't pay attention to their environment and are more likely to trip as well. And also I've included a loonie because it's very expensive. And I would encourage you, the next time you're working in the pharmacy or visit a pharmacy, to actually look at the products that are available regarding absorbable undergarments for males and females, and just do a cost estimate of what it would cost for a single pad or a single brief. These are products that are very expensive and they are not covered under most plans. And so some people use up to 8 pads or 8 absorbable briefs a day if they can't manage their incontinence. And you can see how that can really add up. It also affects some of the other interventions that we do for individuals, such as in rehabilitation. Often for older adults with arthritis, we have aqua therapy or pool therapy to support their body weight. Well, they do different exercises as part of rehab, and individuals that are incontinent are not allowed to go into the pool. And so that affects how we rehabilitate individuals with physical therapy needs. You'll also see in some of your other notes other sequelae such as infections that occur. So urinary incontinence increases urinary tract infections, bladder infections, and skin damage. And then also there's intimacy that is affected. So individuals don't want to have sexual contact. They're very embarrassed. They can lose control of their bladder function during a sexual encounter, or they're worried about the odor that is associated with that. So it's not simply just a bladder issue. This affects all areas of someone's life. Because all of you are continent, you might think this is simple or trivial, and you've known how to be continent since you were about 3 years old. That's usually about the time children are potty trained, and maybe by about 5 or 6, you're really confident you can manage your bladder function on your own. However, there's quite a few steps involved, and you have to appreciate the sequence of those steps. So individuals have to be aware of the sensation from their bladder. They have to be aware that that means they're going to be have to urinate. They have to look for a bathroom. They have to know how to use the toilet, lift up the lid, or use a urinal. They have to know how to undress properly, so removing their pants or their underwear, and then so there's a lot of steps involved. So someone with dementia who does not have good cognitive ability is going to have a lot of difficulty being continent. So you'll see very high rates of urinary incontinence with individuals who have dementia. You have to be mobile, so it's challenging to quickly get to the bathroom if you have a cane or a walker or in a wheelchair. There's manual dexterity required to loosen clothing or lift up the toilet seat, etc. And whether you sit on the toilet or stand at a urinal or stand at the toilet, a lot of balance and coordination is required. And so for some individuals, this is a very difficult thing to do, for older adults especially. And so they're more likely with some of this difficulty to be incontinent. And then the last is a motivation to stay dry. If you've ever potty trained little children, you'll realize sometimes they intentionally wet their pants when they're angry. And the same can happen in older adults who perhaps they're angry at the nursing staff, or they want to be a difficult patient, or they don't understand because of mental illness. They're managed by psychiatry. They're not motivated as a healthy individual would be. So sometimes it can be a combination of all these things, but you can see those most affected are older adults because of all of these requirements. In terms of the pathophysiology, I'll point out that we talk about men's health in Pharmacy 499. That's a third-year course, and you'll study quite a bit more about testosterone and its role in supplementation at that time. But I'll just highlight a few things with these graphics. That a normal prostate should look maybe smaller than a timbit, nice and smooth around the neck of the bladder. And as the prostate grows in older men, it becomes a little bit less smooth. It's a bit more lumpy, and it starts to grow and fill up all the space in the pelvis. And so the only sort of empty space is when other organs collapse. So the bladder starts to be closed off. And so the bladder neck especially is pinched off. This is because testosterone causes, it has an active metabolite, dihydrotestosterone, and this causes cell growth. So as you can see, we're going to be talking about DHT in a few slides in terms of how we can address this excessive growth of the prostate. We talked about older adults having increased risk of lower urinary tract symptoms. There's quite a few changes that occur with age. Again, it's not normal that they become incontinent, but because of these changes that occur with aging and the other requirements of continence, older adults are most affected, and that is why, based on my work in geriatrics, I'm giving you this lecture, because out of all faculty members, I work mostly with incontinent patients. You can read some of these changes, such as a smaller bladder capacity, and then also changes in terms of nocturnal fluid excretion or an uninhibited bladder contractions. Again, these changes don't mean that the individual necessarily becomes incontinent, but it definitely increases their risk. I've listed the risk factors for all the types of lower urinary tract symptoms. Again, there's a number of different types, but these are the 5 main areas. If you are able to remember, physical status, genetic, neuropsych, trauma, and associated causalities, this will help you categorize all the different risks. For individuals who are older, we mentioned physical status, so changes. So we already know being older increases your risk of lower urinary tract symptoms. Being female and being obese, especially central obesity, so that's in both males and females, increase your risk. That puts additional pressure on the bladder, and so whether that's male or female, there's probably going to be more urge and stress incontinence in those individuals. In terms of physical activity, this can increase stress incontinence, so very bouncy activities like running or jumping can impact stress incontinence. A lot of people don't talk about this with their parents or grandparents, but if there's a family history, it could be because of the size or structure of the bladder, your bladder capacity, that can be determined genetically, so it might be something or another associated causality that increases your risk. There's neuropsych conditions, so we talked about an association with depression. Often in psychiatric patients, there's a little bit less motivation to stay dry, and also there is quite a few side effects from neuropsych medications. So antidepressants, antipsychotics, anxiolytic medications, which you'll cover in psychiatry, do interfere with bladder function. In neurology, multiple sclerosis patients, stroke patients, spinal cord injury patients also have abnormal innervation of the bladder, so they don't have the same sensations. They can't control their bladder as someone without those neurologic conditions would, and so you'll see very high rates of urinary incontinence in neurology patients. Trauma, childbirth is listed as a physical trauma related to the pelvis if it's a vaginal birth, and so that can cause some damage to that area and can impact stress incontinence later on. But in men, there can be other surgeries or radiation, for example, after a cancer in that area related to the colon, the bladder, the prostate, and then that leaves that individual at greater risk of incontinence. You're already covering inflammatory bowel disease in associated causalities in your GI module. There's others that might surprise you, such as constipation. Often it can be very hard stools, and then that can cause some pressure on the bladder. But it can also be because when you're constipated, your body sends out sort of a parasympathetic surge to try to move the stool, and that parasympathetic surge also hits on the bladder and causes contractions of the bladder. So not managing the bowel well can also lead to bladder effects. In menopause, we'll talk about in stress incontinence as there are changes related to the tissue around the bladder and the vagina that help support the pelvis in women. In your notes, I've given you a few examples to help maybe memorize some of these risk factors, and we'll talk about some examples of medications as we go through each type. It's meant to be easy to remember, so they've used the word diapers. However, they're switching it to dippers, as there's not a lot of evidence right now that atrophic vaginitis increases your risk. It's common in older women who have incontinence, but it's not clear that that's the cause. So the newer guidelines are referring to dippers, but you may still see some examples in the literature for diapers. And a drip, another not very flattering, but another way to memorize the risk factors. So I would never test you on these acronyms, but they're just available to you to help you maybe remember as a bit of a study cue. In terms of the medications, of course, as pharmacists, we're very concerned about medications that worsen lower urinary tract symptoms in addition to what we're going to study about managing lower urinary tract symptoms. Anything that affects awareness is going to decrease your response to the sensations that you have. And so alcohol is one of the greatest effects on awareness. And so even in young individuals, we sometimes find they become incontinent when they've had too much alcohol. So it's not just the volume of liquid consumed, they're not aware of those sensations. Psychotropic medications make people a little bit obtunded, often sleepy, and so those medications can decrease your awareness, as can muscle relaxants or opioid medications. The diagram you see on these slides is called a lollipop diagram, and this can be used to teach patients. It's a very simple way that we use to explain the effects on the bladder. So the round circle is, the blue circle is the bladder, and the stick on the lollipop represents the urethra. And so we can show at the neck of the bladder that alpha agonists, so medications like decongestants, are used at the bladder neck and affect the sphincters, so it contracts the sphincters, and individuals do not urinate. Anticholinergic medications allow the sympathetic system to take control, and so the bladder is relaxed rather than contracted, and so these medications cause people to retain urine. Calcium channel blockers that are often used in cardiology can also cause a relaxation of the detrusor. Not as profoundly as the other two medications I've shown on the diagram, but that can also be a risk. Medications that increase urine loss include medications that increase urine volume. So anyone who's given a diuretic, there's going to be more and more fluid filling the bladder, causing some stretching, and so then that's going to have a reflex contraction. And so anyone on a diuretic is at increased risk of urinary incontinence. Cholinergic medications, we sometimes use these for dementia, increasing acetylcholine in the brain, but this also increases acetylcholine peripherally, and that causes contraction of the bladder. And then alpha antagonists relax the bladder neck and allow urine to flow out. This very busy diagram is a summary of a guideline. So this was compiled by a pharmacy student I had worked with on a research project, and also a team of experts in lower urinary tract symptoms. And this is a guide for pharmacists to consider. So at the red points, that is where a pharmacist could refer to someone else, but you'll notice there's lots of sort of black parts of this diagram, which is where a pharmacist could act in terms of making lifestyle recommendations that you're going to cover with the nurse, and doing some assessments, modifying some of the medications, and perhaps even prescribing treatment. So there's quite a role that pharmacists can play in the community, and we've also tested this guideline that patients do want to learn more about how they can manage their incontinence. This is an example from males, and again, this publication is available in the Canadian Pharmacist Journal, and it's listed in your study notes under Gabriel et al. CPJ. I want to point out that there's over 22 guidelines, and then there's sub-guidelines. Say, for instance, the Canadian Urologic Association has published guidelines on lower urinary tract symptoms, but now they have a new guideline just on overactive bladder. There's also international societies and reproductive societies that have guidelines. And so there's some consistency, but also slight variations between them. And so what we've tried to do with the last two diagrams I've shown you is synthesize those guidelines for the best recommendations for pharmacists. So be careful if you look at all these different guidelines, it can be overwhelming, but focusing on what the role of the pharmacist is is pretty straightforward and consistent amongst these guidelines. In terms of evaluating individuals, there's quite a few different tools that can be used. There's questionnaires that you can use in a community pharmacy, in a clinic, in the hospital, but it's probably easiest to just ask one or two questions, and instead of saying, do you leak urine, asking how often do you leak urine is a good starting point, because it normalizes that a lot of people do have this problem and you're comfortable talking about it with patients. Or do you use pads or protective garments? So individuals may not feel that they have incontinence, but they're afraid if they lose control, so they wear pads. And so this is a sign that they're probably going to be at risk in the future of having incontinence. You can use some of the official questionnaires or simply use these questions. This is a good starting point, say when you're doing a medication review in the community, to get people talking about it. Often they don't bring this up with their family physician. They're afraid to discuss it. They're embarrassed. And so this normalizes this and begins the discussion so they can start to have treatment. The workup for lower urinary tract symptoms is quite extensive. We don't just look at the bladder, and we don't just ask about their bladder symptoms. We go through a whole medical history, because there may be a medical condition that is affecting the bladder. There might be nothing wrong with the bladder itself, but it's another condition, such as their heart failure and their volume overload. We also look at surgical history, because anything in the pelvis, the abdomen, could affect how the bladder functions. Of course, part of this is to review the medications, and I gave you previous examples of medicines that affect their bladder function. Gynecologic history, so how many children have they had, were they vaginal births, any other surgeries, pelvic intervention, that would be appropriate to review. Urologic history, so any changes with the bladder, any surgeries, any catheterizations, and then we also ask about quality of life. So how dramatic is the lower urinary tract symptoms, how much is it impacting their lives, and how much have they reduced their activities and socialization. I've given you a whole slide on the urinary history. This will be reviewed by the nurse as well, but we don't just ask how many times a day you urinate. We ask how many, what those patterns are like. Are there certain times of the day where it's more frequent or not? For instance, at night can be very disruptive. And to describe the incontinence, is it sort of intermittent trickling, or just a few drops and then you have to force the urine out, or is it a very sudden sensation with a rapid stream? And so we ask quite a few details about how they're urinating. We also ask about their fluid intake. It's sometimes surprising for people, but they cut back on their fluids, thinking that's going to help their incontinence. That is not the case. It actually worsens incontinence, because they have to, they end up with a very dehydrated or very concentrated urine, and that irritates the bladder. So fluid intake is very important for us to review. If there's too much or too little, that's problematic. And then bowel pattern, we already talked about the importance of managing constipation, especially in managing the lower urinary tract symptoms. This is a little bit of a fuzzy example. It was something I scanned in, but an example of a bladder diary. You can find these online as well through various drug companies or associations. They provide an opportunity for the patient to write out for about 3 days what their bladder experience is like. So you can see for every hour of the day, they're supposed to document what they're drinking, and then urination, small, medium, or large, and sometimes that's open to interpretation. There's some studies that support that individuals should, for 3 days, measure the volume of urine, but sometimes patient perception is still valuable. In terms of accidents and leaks, if they leak a little bit or leak almost all of their bladder contents, That's important for them to document. And then how they feel in terms of an urge to go, and then activities that they were doing, such as running, maybe they were distracted by something else. And so this, over 3 days, can give us a bit of an idea of what type of incontinence the individual is experiencing. And you will have an example like this to work through in the seminar. Other evaluations include a physical exam. So we don't want to miss a situation where someone might have multiple sclerosis, and this is one of the signs that they're having urinary incontinence, or if they've had a stroke and it wasn't picked up by someone else. So this is important that we do a full neurologic exam, a pelvic exam in both males and females, rectal. For example, we wouldn't want to miss some sort of cancer at that point, but also identifying constipation. And then musculoskeletal, if the person has some sort of disease that impacts their mobility, or if they're simply deconditioned. So a full physical exam is important. We also do quite a bit of laboratory workup. I know in cardiology, PVR is related to resistance, peripheral vascular resistance, but in urology, that means post-void residuals. So when you see PVR in these cases, that's what we're referring to. And that means after someone has urinated, what's the residual volume left in the bladder? There's usually approximately 60 milliliters. If someone is up to 100 milliliters, that can be problematic. So individuals should be able to avoid most of their urine and with just a little bit of residual. We also order a urinalysis. So for example, someone could have diabetes, which is causing a really dramatic increase in urine volume. So we want to be sure that we detect those types of metabolic conditions. And then urine culture. If someone has a urinary tract infection, that's going to cause irritation. And so that's often straightforward to treat. So we identify an antibiotic that would be appropriate, treat the urinary tract infection, and that often resolves the incontinence. We also do blood work as a metabolic survey to identify underlying conditions. If we still, after all of this examination, history, laboratory testing, can't figure out what's going on or why the patient has bladder problems, we will do urodynamics. And so this is quite a bit more invasive. The individual sometimes has probes inserted in their rectum or vagina. They have to urinate in a setting where it's a special toilet that measures the flow. And so it can be a little bit embarrassing for patients. So we reserve this if nothing else is really working or nothing else is helping us to identify the cause. This helps us see if there's specific issues with the sphincter or certain parts of the detrusor, for example, that are weak or damaged. There's 4 main types. We are not going to discuss in-depth functional incontinence because that does not pertain directly to the bladder, so we'll focus on the first 3 types in this lecture. We'll start with urgency or overactive bladder. This is the type that has the most sort of public awareness because of all the campaigns and the most medications for treatment. Overactive bladder, or OAB, as many drug companies are using that term, relates to an urge to go. This used to be called urge incontinence, where someone has to quickly rush to the bathroom. Suddenly they're sitting calmly and their detrusor contracts dramatically and they have to very quickly void. If they lose their control of their bladder, they often have a very large amount because the bladder empties itself. So it's not just a little trickle. If they have 300 milliliters of urine in their bladder, they lose mostly that 300 milliliters. And so you can imagine that's very embarrassing. It's not something that's easy to hide. And if you lose control of that much urine, it really soils your clothing. However, between episodes, they're usually dry, so it's not like a constant trickle of urine. It's specific episodes with large volumes being lost. There's not usually any retention, so the post-void residual is very low. Now, when we ask people how many times they void, This is something that most people don't think about unless they're recording in a diary. So I would encourage you, before you come to the seminar, just take one day over the next week and record how many times you urinate. It's normal to urinate about 8 times a day for adults. Once you start getting up to 13 times a day, that really starts to interfere with your life, and so that's kind of a threshold where we have to act for patients. So just keep track one day and we'll help you orient, because individuals with overactive bladder often have episodes where it's 13 or more times per day, and that is very disruptive. You can imagine if in every lecture you have to get out of the lecture hall and run to the bathroom, or someone's at work, someone's in a situation where they're driving quite a bit. This is very disruptive. The mechanism for overactive bladder can be central or local. It can be related to systemic medications or something locally acting. So the reason spinal cord injury or multiple sclerosis patients might have issues, or someone who's had a stroke, it may be something centrally. So in the brain, they're not able to control or respond to the insults that have occurred. There can be local irritation, so we talked about urinary tract infections or concentrated urine in someone who is dehydrated, causing irritation and the bladder contracting. And then medications that we talked about, such as cholinergic agents, increase contraction. So the detrusor can be hyperactive in these situations, and that causes the bladder to be overactive. The next type is stress incontinence. This is most common in women, but can also occur in men. This is where there's abdominal pressure to compress the bladder, and if the bladder neck is not very strong or supported, then bladder is forced out. So this happens often in women after vaginal childbirth. So there's some damage and stretching to the musculature in the pelvis, so the bladder neck is not supported. And you can also see this happens in pregnancy as well, where there's a lot of pressure put on the bladder. In men, if they've had some type of surgery for the prostate, this can damage the bladder neck, and they can also have stress incontinence. So during this time, they might find when they cough or laugh, something that in a very transient way increases abdominal pressure, that forces some urine out. And there's usually just a small amount, maybe up to 25 milliliters, usually not very much. So this can be absorbed by a pad versus a full brief. And it only happens when they have that increased abdominal stress. So if they're just sitting comfortably, no coughing or laughing, then there's no concerns. Because there's no retention here, the post-void residual is also low. We mentioned some of the mechanisms already, so pelvic floor laxity, not supporting the bladder neck, damage to the sphincters, so there's outlet incontinence, and any sort of pelvic or prostate surgery that would cause damage around the bladder is going to be problematic. Very few individuals have intrinsic sphincter deficiency, and this would be often picked up even in childhood. Overflow incontinence is the last main type that we'll focus on in terms of treatment. This relates to the bladder neck often being too tight, so individuals end up having more and more urine accumulate. Eventually, there is so much urine in the bladder that the pressure exceeds that at the bladder neck, and so a little bit is forced out. So they often have frequent dribbling. This often happens in older men because of an enlarged prostate compressing the bladder neck. But there can be other reasons for compression. We gave examples such as constipation, so large hard stools, or perhaps something related to a cancer, some sort of malignancy there as well. Because there is a problem with outlet obstruction, patients do have increased post-void residual, so this distinguishes this particular type of incontinence compared to the others. As I mentioned, the most common cause is outlet obstruction with an enlarged prostate. That's almost all cases. but a few other examples are listed here. It's quite rare to have detrusor underactivity, where the bladder just will not contract. This can happen after a spinal cord injury, after a stroke, some individuals after having urinary retention for such a long time, such as a large prostate that they didn't have assessed medically and have surgery for. Eventually the bladder is so distended that it no longer contracts properly. But this is quite rare, and in these cases it would require quite a bit of review by a urologist, probably a neurosurgeon may be involved as well for some support there. So rare but quite serious if your bladder does not contract. We also talk about mixed incontinence, and usually this means someone has urge and stress. Because stress is most common in women, what we're usually talking about here is a condition in women with mixed incontinence. Functional incontinence is the last type that I'll mention. There's quite a bit of discrepancy amongst experts in geriatrics or urology if this really exists. Partly it's criticized as not being a real condition because there's not a problem with the bladder. So this is where someone has difficulty toileting. So being in a wheelchair makes it difficult. If someone has sensory impairment, such as visual impairment, they can't find a bathroom. Environmental barriers. So often this happens when people go into hospital. They're kept in bed with IV lines. It's difficult to mobilize. We give them fluid, often IV fluids, and then they have so much urine produced that they can't get to the bathroom in time, so they become functionally incontinent. There's nothing wrong with their bladder or the sphincters. It's other functional issues or the environment that we've caused that impediment. So we do not use bladder medications to treat this condition. We address the environmental factors that we've put that patient into. The goals of therapy, you can imagine, relate to addressing the symptoms, preventing the complications, and improving someone's quality of life. If we're going to use treatments, we want to minimize those costs and avoid side effects. I'll be focusing on the 5th and 6th types of interventions. It's a little bit backwards. I know you're going to be meeting with the nurse educator, and she'll talk to you a little bit about education, lifestyle, behavioral, and also mechanical interventions that can be used for patients. And they do go in sequence. We have them numbered because we do want to start with education. Patients can make a lot of changes when they understand what's causing the condition. For example, avoiding dehydrating themselves, avoiding that concentrated urine. So educating them, that can resolve much of their complaints related to lower urinary tract symptoms. So we make sure we've addressed all those potential interventions before we start drug therapy. And then surgery in some cases is appropriate but is a final option. I'll discuss surgical and pharmacologic treatment for each main type of lower urinary tract symptoms. For overactive bladder, you'll remember this is the type where the detrusor contracts and the patient very quickly has to go to the bathroom, and then they lose all of the contents of their bladder, so often hundreds of milliliters of urine. There's no surgery that is appropriate for this treatment, but we do have pharmacologic options, and the most common is usually anticholinergics. There's also a new sympathetic drug treatment that can be used that we'll talk about in a couple of slides. But the sort of gold standard is to use an anticholinergic because this will cause the detrusor to relax. This is listed as what we call grade A, or the highest level of evidence. So we have very strong evidence from randomized controlled trials that giving someone an anticholinergic medication decreases the overactive bladder symptoms and reduces the number of incontinence episodes. The oldest medication we have for this is oxybutynin, and the newer medications are often a little bit more selective, there's more selectivity if you look at RX files, or in the study notes I've given you, more selectivity for muscarinic receptors such as subtypes M3 over M2. Oxybutynin is the least selective, but they all work. They all reduce the same symptoms and decrease incontinence episodes in people with overactive bladder. In terms of expectations individuals have, you'll notice that the medications are maybe a little bit silly. The names, if we go back and look at the past slide, you'll notice names like Enablex. So really trying to get patients the idea that this is supporting them, enabling them. And the original medication name for oxybutynin was Ditropan, and this is an anagram, and it stands for not a drip. So that's a little bit of trivia that you likely won't forget, but will probably not show up on any exam. But I bring it up because individuals have these very unrealistic expectations about how these medications work. They actually think that it will lead to not a drip. All of their symptoms will be gone. That's not the case. They reduce symptoms, they improve the symptoms for individuals, but sometimes they still have a few sensations of having overactive bladder, and maybe a few times a day will still be rushing to the bathroom, but it makes it much more manageable. There is a reduction in leakage episodes, so if individuals are having incontinence, it can reduce close to half to 1 episode a day. So that's not dramatic. If someone's having 8 or 10 episodes a day, that might not be a big impact. So again, you have to review with patients what's realistic. It's not going to completely reverse all of their problems and they'll have no symptoms. It improves their symptoms a little bit and reduces the actual incontinence episodes. However, you'll see xerostomia or dry mouth is dramatically increased, and this is the main side effect that's a concern with this drug class. Comparing one of the medications to another, there's not evidence that one is superior to the other, so we make choices based on dosing frequency, drug interactions, the other parts of the patient's regimen, the extent of the side effects. So we can tell patients that if we switch between one drug or another in this drug class, they'll probably have pretty equivalent benefit. In terms of the selectivity, I've already mentioned oxybutynin is least selective. So I would like you to know that fact. It's the least selective, and that means it has the most side effects because it's not just connecting with the receptors on the bladder, which are mostly M3. It's affecting muscarinic receptors all throughout the body. And so you can imagine having anticholinergics head to toe. Side effects are really quite miserable. So the more selective agents are often preferred for individuals in terms of tolerance. We also make selections based on dosing frequency. So the original oxybutynin product was actually 4 times a day. So that's pretty miserable, but there are other products available such as the gel, a patch that can be used, which also has a little bit lower risk of side effects. You'll see some of the newest medications are only once daily, and so often these are preferred by patients. You'll notice there's also a difference between these medications in terms of which CYP enzyme or how much of the medication is renally eliminated. This helps us determine which medications might interact and will help us decide what might be a preferred medication. You'll notice all of the medications have potential interactions based on how they're eliminated. This class of medications has numerous interactions. As I previously noted, CYP2D6 and 3A4 are most notable. I don't expect you to memorize this for an exam, but it is helpful in seminar if you're selecting one product over another. You might choose one that minimizes interaction with the patient's current regimen. We also have pharmacodynamic interactions, and there's other anticholinergics available, plenty of them over the counter, such as antihistamines. Some prescription products, such as tricyclic antidepressants, are also potently anticholinergic. So these side effects can really accumulate in older adults. We also have cholinergic agents, the most common being cholinesterase inhibitors that are used to treat dementia. Because older adults most commonly have lower urinary tract symptoms and are the age group most commonly to experience dementia, it's common to see patients have both of these conditions, and therefore people want to prescribe both an anticholinergic and a procholinergic agent. This can counteract the effect of both these medications, sort of neutralizing the effect but giving the patient a lot of side effects. So we have to be careful which product or which disease state is the priority and how we go about treating that. Obviously, cholinergics can worsen the lower urinary tract symptoms and counteract the effect of the treatment for lower urinary tract. So we will discuss this more in third year when we talk about psychiatry conditions such as dementia. But be aware at this time that these are pharmacodynamic interactions where the drugs can neutralize the effect of the other. Some of the contraindications you should be familiar with, having covered GI and ophthalmology at this point. We would avoid using these medications in patients with glaucoma. It can worsen the pressure in the eye and potentially make the patient go blind. So we'd have to make sure their glaucoma is very well controlled. And in some cases, we can use a very selective or one of the newer anticholinergics, which would have less affinity for the muscarinic receptors on the eye. Obviously, in men with large prostates, we try to avoid these medications because the patient needs to address the obstruction first. This is a summary of the most common and most difficult side effect for patients. As pharmacists, other health professionals, we all often think of this as a nuisance or trivial side effect, just dry mouth, nobody dies from this. But this is actually very serious for patients. They can have sores in their mouth, and it's also difficult to eat when you produce no saliva. It's difficult to chew your food, and in older adults this can be a problem if they have dentures or already have some difficulty eating, and especially in dementia patients who do not eat very much. You can see oxybutynin oral on the left-hand side. Over 90% of patients experience dry mouth. So this is the #1 reason why people stop taking their medication, even if it's having an effect on their bladder. This is such a miserable experience for them. And you can see that the newer products, more selective products as we go across, have a lower risk of dry mouth, but still not trivial. Even the oxybutynin patch, which allows different metabolites to be formed, has about 10%, but that's still enough that we have to warn patients that this is a common side effect. So chewing or sucking on ice chips might be an option, but they would have to do that all day long. Sometimes saliva substitutes are also helpful. We often think of those as products for patients with cancer, but saliva substitutes are very helpful for individuals on anticholinergics for lower urinary tract symptoms. The other side effects, you've covered this in first year. You know the anticholinergics can affect every organ system from the brain down, and you already know that in a severe case of toxicity, someone can even lose control of thermoregulation and become delirious. So we would monitor these side effects very carefully if someone is increasing their dose of the anticholinergic, and especially if they're on other anticholinergic medications. Mirabegron is another option for patients with overactive bladder or urge incontinence. It's actually an adrenergic agent, so in the same way we'll have the same effect as an anticholinergic product. It will allow the sympathetic system to take control, but it will not cause the anticholinergic side effects. The beta-3 receptors are in the bladder wall, and so this forces the detrusor to relax, allowing for more storage of the urine. There are some similar side effects such as constipation, but these are really not so common. Mostly patients have nausea and some headache. Rarer side effects are cardiovascular risk, and this is a concern because it's often many older adults who are using these products. But patients can have a slightly increased heart rate and blood pressure, and notably a prolonged QTc interval. So this can lead to cardiac arrhythmias. So we are concerned. There's beta receptors in other parts of the body, notably blood vessels and the heart. And so even though this product is beta 3 selective, it's not 100% selective. So we are concerned if patients have a history of cardiovascular illness or a history of arrhythmias in the past. It's also a little bit more pleasant for patients because it's only dosed once a day and again does not have the dry mouth effects. This particular product is the first in a class where there's many more being developed. So in the coming years in your practice, you'll see many other drugs with the ending of Vagron. It's not currently covered as a first-line therapy by Alberta Blue Cross, but because of the better tolerance and no dry mouth, we are seeing quite a few patients start on this medication. There's other alternatives. What's becoming more common is to use botulinum toxin. So this is a medication that has many medical indications, not just cosmetic. It can be injected by cystoscopy, so a scope is taken into the bladder. This is done in hospital, obviously, and the patient has little injections all throughout the detrusor. You can see in this diagram here that there's quite a few injection sites, so it's not just a single injection and then the bladder is controlled. It helps minimize the movement of the detrusor. You can see obviously if this is too much botulinum toxin is injected, the bladder becomes flaccid and will not contract at all, and then patients can develop retention. So this is usually done by a specialist, and this is for extreme cases or in situations such as multiple sclerosis or spinal cord injury where other medications are just not effective. Other options such as tricyclic antidepressants are generally not used. If the patient is already using this product for neuropathic pain or for sleep, TCAs may be helping their overactive bladder, but it's not considered a first-line approach. And cyclamine and fluvoxate, these have limited evidence. They are often used in gastrointestinal patients with GI illness, sometimes as antispasmodics. And so they may work on the bladder, but minimal evidence, minimal research in terms of bladder patients. We now will talk about stress urinary incontinence. This shows why it's problematic in women, and especially problematic in women who are pregnant. You can see where the uterus is, and as a fetus is developing, the fetus basically rests, all that weight of the fetus, placenta, other tissue, rests on top of the bladder and squishes the bladder. And so this is why pregnant women have to urinate so frequently. And you can also see the thin, very thin layer of pelvic floor muscles, and having months of this extra weight being suspended by this thin muscle often causes a lot of stretching and distortion and weakness after the pregnancy. Also, if men have had a surgery that involves movement or cutting of the pelvic floor muscles, this can also lead to stress incontinence in males. To treat stress incontinence, we want to make sure that the bladder neck is closed off so that the urine does not leak out. However, there's very few medications that really work well for this. Mostly we will end up using surgery for these patients, or something mechanical like pessaries, or potentially lifestyle intervention. However, alpha agonists, which are often referred to as decongestants if you buy them over the counter, these medications work well to close off the bladder neck. They increase the resistance, and so urine stays in the bladder, so there's not leakage when someone coughs or bends over or sneezes. However, these medications also cause cardiac arrhythmias and can make a patient feel very anxious. They're very stimulating products. And so if they're taken throughout the day, individuals have a lot of trouble sleeping at night and may have insomnia and a lot of anxiety that goes along with these products. In older adults, we're particularly concerned about increase in blood pressure and cardiac arrhythmias. And so we tend not to recommend these agents. There might be a few younger patients, women who maybe recently had childbirth, who can handle a more stimulating medication early in the day, but not very much evidence to support these. Again, the evidence is quite limited. We don't have very good randomized controlled trials, and it's preferred to use pelvic floor muscle training, and so you'll study that in more detail with the nurse educator. So surgery or pelvic floor muscle training or other lifestyle changes are considered the approach of choice, and we really want to minimize drug treatment here. Another option for women is to use hormone therapy. This helps replenish or build up the tissues in the pelvis, notably around the urethra and the vagina. So this is after, or as a woman is going through menopause and is postmenopausal, we can see a lot of atrophy there. It's also helpful to use topical therapies if the patient has a pessary that's going to be inserted that helps protect the tissue there. So that's another option for individuals. In general, we don't use oral hormone therapy just for bladder symptoms. The woman would use oral hormone therapy if she also had other menopausal effects such as hot flashes or was treating other withdrawal effects from the estrogen. The last product that we'll talk about for stress incontinence is duloxetine. It's actually a medication labeled in Canada for treatment of depression. So it's a stimulating antidepressant medicine, and it's also been shown to have some benefit for neuropathic pain. So you might see this also used in people with diabetes. The medication increases the tension at the sphincter, and so this helps retain urine. Now you can see this is a problem if patients are using duloxetine for depression and they had no bladder symptoms. Now they might be put at risk of retaining their urine. But for someone with stress incontinence, this medication can be helpful. One of the challenges is that the medication is not labeled for use in Canada for stress incontinence. So the doses that have been studied that are most helpful for bladder symptoms are 40 milligrams twice a day or 80 milligrams, and you'll see that recommended in various guidelines. However, in Canada, for depression, the product was approved at 30 or 60 milligrams. And so we sometimes will try the 30 or the 60 milligram dose to see how that works in patients. You do have to be aware this is considered off-label, but it is recommended in guidelines, and there is evidence to support this. But it is somewhat unique in Canada. The company didn't apply for that in their product labeling. And notably, the patients usually experience a little bit of nausea, but this is generally a fairly well-tolerated product. The other options relate to surgery. You might hear patients describe having a sling procedure, and you can see from these basic cartoons that the bladder neck is suspended against the abdominal wall, and so this is helpful in terms of that laxity that occurs after a pregnancy or after a surgery. So there's less pressure at the bladder neck and less leakage. These are very common procedures done in Canada. There's quite a few people with expertise in this area, and this improves symptoms about over 95%. So patients really have a dramatic response. There are some complications over time. Maybe the stitches or the suspension might come loose, and so we have to monitor patients that they continue to have benefit from this, or perhaps a revision of that surgery. There's some research on bulking agents, and patients generally like the idea of this, that fat is taken out of other tissues from their body where they don't want the fat, and then injected around the bladder neck. This is sometimes considered positive in that it's not introducing a foreign substance. It's the patient's own fat, and that helps support the bladder neck. But there's much more research that needs to be done in this area, but this is something new that's been going on. And so you might see some patients talk about this kind of procedure when maybe the bladder suspension didn't work very well for them, or they needed revisions, and now they're moving on to a bulking agent intervention. For BPH, this is unique to men. You obviously have to have a prostate, and we often have patients that undergo what we call watchful waiting. So this is where the symptoms really aren't so bad. Remember, this is not cancerous, but this is where the prostate is enlarging to the point that maybe it's a little bit inconvenient, to the point maybe it's so extreme the patient has severe retention and needs a catheter in order to expel the urine. The most effective intervention is surgery, and so we'll talk about that first. Then patients can also do catheterization to bypass the obstruction of their prostate, and then there's drug therapy, so we'll talk about the few drug classes there. So this is an image of a normal prostate. You can see there is not much room in the pelvis for organs to become larger, so as the prostate grows, the tissues don't allow a lot of give, and so it's the bladder that ends up being compressed, and the bladder neck is almost completely sealed off in a very large, with a large prostate growth. This is an example of a surgical procedure. It obviously doesn't look very pleasant, but this is almost 100% relief for the bladder symptoms once this is done. This is the transurethral resection of the prostate. So transurethral meaning the abdomen is not cut open, the pelvis is not cut open. They go in through the urethra, and then through the urethra sort of have a little shaped scalpel in the shape of a loop, and that cuts out or dissects out the enlarged prostate, and then that material is withdrawn through the cystoscope back out the urethra. So in most cases, patients have a little bit of bleeding out the urethra afterward, but the healing is fairly quick, and there's no other abdominal incision. So it's a fairly straightforward procedure, very common, and usually provides the patient with quite a bit of relief for their bladder symptoms. So this is considered the gold standard of therapy, and this has been done for decades. Some patients are concerned about having surgery. They're uncomfortable with that idea. They don't want to have more surgeries, or maybe they're quite frail and don't want to be sedated or under any anesthetic. So we do have some options for patients with milder symptoms. There's two different drug classes. The first that you'll see is the 5-alpha reductase inhibitors. And at this point, it's important to note that you're learning about alpha blockers, alpha agonists. 5-alpha reductase inhibitors are actually related to hormone production, and they are not related to the sympathetic system. So 5-alpha reductase, you'll recall from an earlier slide in this set, is the enzyme that converts testosterone to dihydrotestosterone. DHT is about 10 times more potent than testosterone, and that's what's causing the prostate growth. So if we can intervene with a medication that stops the formation of DHT, that means the patient will still have some testosterone circulating, but not this really potent metabolite, and that will start to minimize the growth of the prostate. This is helpful in very large prostates that have overgrown. However, because prostate growth is very slow, once we stop the formation of DHT, it takes many months for the prostate to shrink. In fact, 3 to 6 months. And so that's important for patients to appreciate. This is not a medication that will help them urinate better tomorrow. It takes quite a bit of time. And dutasteride is the one that probably works a little bit faster, closer to 3 or 4 months. But even that, for some patients, can feel like a very long time. But generally quite effective in these patients with large prostates. As I mentioned, dutasteride works a bit faster. The brand name is Avodart, and it's the newer product, so a bit more expensive. There's also a little bit more reduction in prostate size, 27% in the studies. However, finasteride is also a fairly reliable product, reduces prostate size as well, and we have quite a bit more experience with finasteride because it's been around for many decades. There's a few concerns with using a product that interferes with testosterone production. The first is that patients might have an effect on their sex life, so they have less of this more potent DHT, so they might have difficulty maintaining erections or lower sex drive. Decreased volume of ejaculate is not too much of a concern, but patients may actually be infertile. They're not producing enough sperm. Other warnings that have come about post-marketing with these products relate to breast cancer. So again, interference with testosterone can lead to an increased response of the estrogen effects in men. And recently, just in the last year, there's a concern about suicide risk with these products. So when we interfere with testosterone, that can affect mood in individuals. So we do have to be careful. These are not trivial medications and can have very, not common, but serious side effects that have to be discussed with the individual. So you can see with some of these risks and impact on sex life for patients, sometimes this is not preferred, and again, why surgery is considered first-line therapy. There's more rapid-acting medications, including alpha antagonists or alpha blockers. These are medications you might see used in individuals for cardiac purposes, such as hypertension. Doxazosin and terazosin are cardiac, so you can see Hytrin for hypertension or Cardura for cardiology. And then we get into selective alpha antagonists, such as tamsulosin. So Flomax is a very obvious name chosen to help patients think that they're going to have maximum flow from their bladder. So the and alfluzicin and silodosin are also newer and more selective agents for the alpha receptors on the bladder neck. They cause relaxation of muscles, so the sphincter opens up at the bladder neck and causes urine to be able to flow out. So this moves the urine past that obstruction from the prostate. Patients have benefit within a week, and so this is a medication that might be used while they start finasteride or dutasteride, waiting months for those medications to work. This medication will work fairly quickly. The newer agents that are selective are dosed about once a day, and there is some debate. If you dose it once a day, should you take it in the morning or at night? These particular medications can be taken in the morning if the patient has more symptoms during the day. Some people recommend they're taken at night, but then the patient ends up having the most effect at nighttime and has to get up frequently to urinate. So once a day means whatever works best for the patient. They can try at different times. Sometimes we're also concerned one of the side effects is dizziness, because this opens up blood vessels as well. So patients can have lower blood pressure and be dizzy. So if they're taking the medication at night and then quickly getting up to run to the bathroom, they're at higher risk of falling. So you have to talk with the patient about when they have the most symptoms and what works best for them. We have some very significant evidence with the alpha antagonists that they improve urinary flow and urinary function for older men. We have research in randomized controlled trials that goes out to 1 year, even though these medications start working within the first week or so. We have even longer open label studies, and so we're quite confident that these are medications that are fairly well tolerated and work quite well to rapidly and continuously allow for urine flow with a large prostate. There's not significant difference in terms of efficacy between these different products, and so in the seminar cases or in practice, you could choose one over the other and still expect urine flow to be improved. You would make a decision about one over the other based on side effects, drug interactions, or if there's a preference for the individual in terms of drug coverage. So other considerations rather than one being superior to another. There are objective ways of measuring flow rate, as I mentioned, with probes, and so that's invasive, but we know this information from studies that flow rates improve, so there's a faster stream. And we also have various measures that we can use, such as the International Prostate Symptom Score, which is also known as the American Urologic Association Symptom Score. And so this is subjective, where patients rate their own urinary activity, how fast the flow is, how comfortable it is, how much force they have to exert to pass urine. And so this improves significantly, almost 40% for patients. There is one unique side effect with alpha antagonists, and that is retrograde ejaculation. This is where the bladder neck is quite relaxed, which allows the urine to flow out. But when an individual is going to ejaculate, normally the semen is expelled through the urethra. But in this case, the bladder neck is so lax that the semen actually moves into the bladder instead. That's the path of least resistance. And so men describe this as still feeling like an orgasmic sensation. They still feel orgasm and there's still pleasure associated with that, but it does feel different. They don't produce an ejaculate, or it's much smaller. And then later it can be disconcerting, depending on the concentration of the urine, as the semen is passed through their urine. So this is something men need to be told about. It's not dangerous. It's not something that they need to be concerned about unless they are trying to impregnate their partner. Obviously, by not producing semen, the partner will not become pregnant. So that would be a contraindication then to using this medication. The most common side effect is actually dizziness. It's not surprising with these medications blocking the alpha receptors on blood vessels or the heart that this could lead to vasodilation. And otherwise, these are relatively well-tolerated medicines, especially the selective agents. They're at much lower rates of dizziness. And again, older men are sometimes not as concerned about abnormal ejaculation, so pretty well-accepted products. In recent years, there's been an approach to using phosphodiesterase 5 inhibitors. These are most commonly used for erectile dysfunction. They relax smooth muscle and allow for blood flow into the penis, which helps with erectile dysfunction. However, it was found that tadalafil specifically works best for BPH. So it allows relaxation of the musculature and dilates the bladder neck as well. So in BPH patients, we also use this at a low dose. So it helps if a man also has erectile dysfunction and BPH. He can use this one medication, and that helps both conditions. It's dosed daily, and that's unlike often when we see erectile dysfunction medicines. Those are used PRN for sexual activity. This medication is dosed daily for BPH. There's a number of contraindications. You'll cover these more in your cardiovascular module and in the men's health and women's health module in third year, where we study erectile dysfunction. But certainly there's a concern with something that is a vasodilator, dilates smooth muscle. If the individual takes this medication along with nitrates, there can be very dramatic vasodilation and then potentially going into shock. The blood pressure drops so much. So we have to be careful if people have angina and are taking nitroglycerin. They cannot be on this particular medication. Because of the vasodilation, people sometimes have headache, and also smooth muscle changes can also affect dyspepsia. There's a few cases, very severe risk of inadequate blood flow in the eye, and people can actually develop blindness from these medications. So we have to be sure we're not overdoing the vasodilation. A number of men also use natural health products. Again, if the symptoms are not severe and the individual is deciding not to go for surgery, a lot of patients will self-treat. We see quite a high use of saw palmetto. It may actually have some 5-alpha reductase inhibition, so slowing the growth of the prostate. And so that's similar to what we saw with dutasteride or finasteride. Not nearly as potent, but maybe helpful. So this is a product that has a fair bit of evidence. There's, out of all the natural health products, some of the most robust randomized clinical trials. It seems like there is probably more benefit than just DHT inhibition. Because there's faster action than we would see with finasteride or dutasteride, and it's possibly due to some anti-inflammatory effects, decreasing the size of the prostate as well. There's not significant interactions with this product, so we encourage, if men prefer using natural health products, this is probably a fairly good choice. There's another form of overflow, one that doesn't involve the prostate. This is where there might be some damage to the detrusor or innervation concerns so that the bladder does not contract. And so the bladder just gets fuller and fuller and fuller, and you can see in this graphic on the left a massively distended bladder. We have some patients sometimes with retention that have over 1 liter of urine. No bladder can handle that. Normally at about 600 milliliters, that's about capacity for most adults. This might be a rare case, but we would use a medication called Bisanacol. You'll notice the clever brand name is Do Void. It would make you void. And this is for individuals where the detrusor is not contracting, so it actually stimulates the contraction. This might be used for patients with poor contractility, temporarily or long-term. You might see it temporarily used when individuals have post-surgical immobility, so they are after an anesthetic. Sometimes it takes a while for the autonomic nervous system to regulate, and so the parasympathetic system does not work very quickly, and in order to generate some stimulation of the parasympathetic system, Bisanacol is given, and so that might be used for a short time in hospitalized patients after surgery, but it's not something that we often continue on long term. The dose is quite variable. There can be low to high doses, so you might see someone, if there's no movement after surgery, at a very high dose. Some patients with neurologic problems may need this at a lower dose, but over the long term. No contraindications other than monitoring for the side effects, such as enhanced cholinergic effects. So this is something that is not very specific just for the bladder. It generally increases cholinergic effect, so it can cause hypersalivation, tearing, increased secretions in the gut, so sometimes some dyspepsia for patients. There's two special populations we do not have time to cover in this particular module. In pregnancy, you'll cover some unique urologic care needs for pregnant women. That's in the 3rd year of the program. And in 3rd year as well, you'll cover pediatrics in pharmacy 387. And there we talk a little bit more about nocturia and special needs of children. In terms of monitoring, we want to look at the symptoms the patient is having. The emphasis of this lecture is on lower urinary tract symptoms. So usually patients have come to us with complaints, they have symptoms, and we need to reduce those. That's the #1 concern, more important than just flow rate or other objective parameters we can measure. It's patient perception of symptoms that needs to be addressed first. If we're keeping a bladder diary check for these patients, we'll help them note if they have fewer episodes, volume of urine, symptoms throughout the day. It's also important we want to reduce absorbable products used. They're expensive, not always comfortable for patients, and carry a bit of stigma. So if our medication interventions and lifestyle interventions and so on help improve that, that's very positive. And finally, flow parameters can be monitored. This is often of interest to health professionals, not as much to patients, but given some of the difficult cases that we have, sometimes it helps to show patients that the medication is working because the sphincters are maybe a bit tighter or looser depending on the situation, and there's better flow rates occurring. The pharmacist has quite an important role. Often these are patients in the community who are not discussing this embarrassing issue with their family physician or anyone else, so we can support them as a first line of feeling free to talk about this and normalizing it. This is a discussion that we can have during consultations that we have with these patients or during their medication reviews. Pharmacies are also a common place to purchase absorbable products, and that's a good time to start the discussion. We can engage in some assessment, so it's often quite clear which types of incontinence the patient has, and we can start to educate them and talk about lifestyle interventions, and also recommend pharmacologic changes, either stopping a medication that's causing problems or starting one. And also engaging the patient with support. So as you will talk about with the nurse educator, connecting patients to physiotherapists, for example, that can help with rehabilitation of the pelvis, or connecting them with a gynecology clinic or the urology clinic where they can obtain additional supports. So the pharmacist has an important role in the community, in other settings as well, in engaging with the care team in interprofessional delivery of care for patients with lower urinary tract symptoms.